Anti-infective agents. This starts on chapter 8, and we're going to move our way in the same PowerPoint right into chapter 9 on antibiotics. Right, yes, and then the next PowerPoint lecture will go into chapter 10, the antivirals. Actually, a few chapters, 10, 11, antifungals, antiprotozoals, 12, 13, I think into chapter 14. So I have tried to break this down because I don't want you to look and think you have to memorize everything in this book. So I'm going to try to make this as simple as possible. And I said this actually is a very good text to help you. In the beginning of your chapters, they give you some glossary of key terms. You should look and get familiar with these terms because not everything is bactericidal. Some things kill and some things prevent replication of bacteria. Culture prophylaxis. Prophylaxis is preventing, giving it ahead of time to try to prevent an issue for multiple reasons. The culture is what grows out. So then you look at sensitivity. Let's see, it says resistant selective toxicity. Oh, sensitivity testing. So when you do a CNS, which you probably know this, but I'm going to say it anyways, you do a culture and sensitivity. Culture grows out of bacteria. Sensitivity tells you what it's sensitive to. What antibiotic will kill that particular bacteria. So it's a culture and sensitivity, CNS. That's why you send it. You get the report. Look, it takes 24 hours for a preliminary report, 72 hours for a final report. But that way, sometimes an antibiotic is started because an infection is obviously there. You start the antibiotic, but you get the culture before the antibiotic starts. You don't have culture results back, but you draw the culture, whether it's spinal, blood, urine, sputum. Believe me, you will forget to get a culture and start the antibiotic and kick yourself when you have to call the provider and tell them. So the reason for this is because you need a true sensitivity to make sure the antibiotic is appropriate. And then some reports will actually give you a degree of sensitivity to tell you which one is better than something else and which ones are definitely resistant. Selective toxicity, when you get into more the neoplastic drugs, you'll see selective toxicity. Sometimes with other particular drugs like antituberculars or something, when it's selective to just kill certain things. Spectrum, how many different bacteria does it kill? So when something is referred to as a broad spectrum antibiotic, it kills probably like gram-negative and gram-positive, multiple things. So that's where in the beginning of these chapters, if I were you, I would look at those terms. You may already know them. If you don't, you kind of want to get familiar with it. So this chapter kind of just gives you, again, terminology, getting you familiar with the anti-infective terminology, uses, different things as we go into the others. I thought this was just a good slide for you on antivirals, antibacterials, antifungals, antiprotozoal, antihemitic, and anti-agal. We are not going to cover any anti-algae ones. Helminths are worms. Protozoans, don't see much. We'll touch on it because you do need to be familiar with it, but like malaria and giardia. But the antiviral, antibacterial, antifungal is much more common. This what just might be helpful. Drugs are designed to target foreign organisms that have invaded and infected the body of a human host. They interfere with the biosynthesis of the bacterial cell wall, prevent the cells of the invading organism from using substances essential to their growth and development, interfere with the steps involved in protein synthesis, after the permeability of a cell membrane to allow essential cellular components to leak out. So what it's really telling you is that antibiotics work at different parts of the cell. That's why some work on some work better on others. It depends on the type of bacteria it's going after. It depends on the part of the body. So what can and cannot penetrate that part of the body to get you that bug. Causes of antibiotic resistance, multiple. Overprescribing. Antibiotics do not kill viruses. Colds are viruses. Most upper respiratory infections are viruses. So many things are viruses. And we've become a society that doesn't want to be burdened by anything. We want to fix now. So they want to get their antibiotic even though it's a viral infection. Antibiotic isn't going to kill it. It's just going to leave it opportunity for more resistant bugs to form. This is the other patients not finishing their treatment. Never assume they know to do that. Always, always, always stress that you are given a certain amount for a reason. You may feel better on day 3, you may feel better on day 5, but you still need to continue the antibiotic because the bacteria is not completely dead. You don't want it to come back stronger and better. Overuse of antibiotics in livestock and fish farming. That's a huge problem. I have in the past 6 months gone to antibiotic free in every which way I can, trying to help my body. There's a lack of new antibiotics being developed. Well, we've had so many. Lack of hygiene and poor sanitation, poor infection control. All these are factors. Okay, adverse reactions. Your text, adverse reactions to anti-infective therapy. When you get your text, it starts on page 93. It talks about different things: kidney damage, gastrointestinal toxicity, neurotoxicity, hypersensitivity reaction, superinfection. All of these are adverse reactions. Adverse reactions are things that are not just side effects, but they're an adverse, something that is negative and that is affected. Can be mild to significant. GI is huge. Anti-infective medications can be toxic, like as we go over some of them, like they'll have a hearing loss with the gentamicin. GI tract, it can overkill the bacteria in the gut, so you have super infections forming in the gut, like such as C. diff. And nervous system, it can cause problems in the brain or neuropathies. Kidney damage with any drug, kidneys can be a problem, and because so many of them are eliminated in the urine. Your text has a couple of boxes talking about, just giving you more detail if you wanted to read it. GI toxicity, very common with anti-infectives because it kills some of the good bacteria that we need to fight while we're trying to kill the bad bacteria. Can be toxic in the liver, causing liver failure, hepatitis. The cephalosporins are ones that can impact the liver a lot, which we will talk about as we get into some of these. So I just put pictures up here to help you think of your kidneys, neurological, liver, and then of course there's what else? GI. I didn't do a picture of the GI. Oh yeah, here we go. Superinfection in the GI. Okay. Classes of antibiotics. Chapter 9 gets into antibiotics. I thought this slide was good. Your text does have a drug list. where it gives you all the classes of antibiotics, whichever place works for you. And for those of you that don't have your text yet, these slides are your information for you. I'm doing my best to make sure you have what you need. So beta-lactams, it has to do with how, again, antibiotics and how they work with the cell wall. So the beta-lactams are across here. The penicillins and cephalosporins, as we talk about them more, are, I call them cousins. They're very closely related. So you have the beta-lactams, aminoglycosides, glycopeptides, oxazolidinoids, as I can't pronounce some of these, the macrolides, lincosamides, which is very closely related. This is kind of a newer class to this, and fluoroquinolones. The best thing to do is to understand the class of the antibiotic and some things that go just within that class. That's the best way to learn these. Your text begins on page 103 with the class called the aminoglycosides. They are poorly absorbed in the GI tract. They are absorbed, so if you think about it, if they're poorly absorbed in the GI tract, they absorb very quickly from an intramuscular and peak within 1 hour. The aminoglycosides are the medications that you'd expect to be giving a shot. Amikacin and gentamicin, streptomycin, and tobramycin. You will not see them in a pill form. They're not absorbed that way, so why would we administer them that way? Contraindicated in renal or hepatic disease because they are widely spread through the body. Holding cell for serious infections because it's widely spread, easily absorbed, peaks in an hour, so it penetrates through lots of areas. That's why it can be good for those really big bugs. But because it goes everywhere, it goes through the kidneys and the liver, so it's contraindicated renal hepatic disease. Adverse effects are central nervous system effects. Like I said, it's going to be GI, neuro, superinfection in the gut, the previous slide, kidney, and liver. So this affects all the CNS, the renal, and the liver. Some of the, with the aminoglycosides, some of the central nervous system effects can be permanent, and nephrotoxicity, neurotoxicity, bone marrow suppression are the big things. So these big guns, amikacin, gentamicin, streptomycin, tobramycin, did you notice anything very familiar in all of those? You hear the mycin on the end of them. Tobramycin, streptomycin, gentamicin, amikacin are the aminoglycosides given intramuscularly, some of them IV, and neurotoxicity, nephrotoxicity, bone marrow suppression. This picture talks about here peritonitis, meningitis, because it penetrates all these things, so that's good things for it to treat. Don't forget they need peak and troughs done. Your peak and troughs, when you give medications, there's peak and trough levels. You draw the peak to see when the medicine's to the level it needs to be. So they'll be given doses and try to get it to a peak. The trough level is the lowest it gets to. Your you will have specific orders written by the pharmacist of when to draw the peak and the trough. It'll be after the 3rd dose, 4th dose, 2nd dose. They've calculated out, they've tried to figure a dose. They don't want it to be toxic to the liver or the kidney, so it's very important to have peak and troughs on the aminoglycosides. So they'll tell you which dose to do your peak and trough, and again, this is one of those tough ones. where you sure don't want to miss it because your neck is in a ringer when you do. Your peak is drawn after a dose. It'll tell you specifically in order, like an hour after or something, because they want to see the peak of the drug when it's at its most, like the aminoglycosides peak in an hour. So usually it'll be written for an hour after you hang the dose that you're going to check a peak level in the blood to see how high is the drug dose going. Does a pharmacy need to decrease the dosage for that aminoglycoside? Your trough is going to be drawn right before a dose is given. So pay attention to those times. I don't know with everything electronic now. I know with the old Mars, when they were written, we would write the P and the T on there with the doses to try to keep you from forgetting it, because your trough had to be drawn right before you hung the dose. Oh gosh, I didn't even realize I had a slide right after this. It's late, I'm getting tired. I just want this information available to you guys for tomorrow, so time you would expect to have spent in the class, at least you can be going through these. Print off your slides, go through this, and be prepared, so don't feel so stressed. So your serum peak and troughs, it gives you your times here, tobramycin, gentamicin, all these mycin drugs. Amikacin is the only one that's name is a little different. These are very powerful drugs, so it's telling you everything I think I already told you. And I said IM or IV crosses the placenta, so obviously you are not going to want to give it during pregnancy. Does not cross the blood-brain barrier, so it's not going to work for an infection in the brain. May cause, I like this picture, ringing in the ears, called tinnitus. Gentamicin is one that you really want to watch for with that. So gentamicin or garamycin, if you get a test question and it talks about this person's on whatever couple of meds, one of them is a garamycin or gentamicin, and they're telling you they have ringing in your ears, what would you do with the problem is you think that it's a toxicity from the gentamicin and may or may not be reversible. The gentamicin comes in ophthalmic, there is eardrops, comes topical, IV, IM, and it can also be given intrathecal or into the spine. Neomycin is the only one in this class that actually is given topically only. It's not an IM. Tobramycin, IM, IV, it can also be in the ophthalmic and actually in a nebulizer. Carbapenems, and you will laugh all the way through the semester with me trying to pronounce some of these. I probably get a lot of them wrong, but this is a very new class of broad spectrum antibiotics. Your text has it when you get a text on page 106. Meropenem is the only one I am familiar with. This it has caused some major fatal GI problems, so I guess they've come out with some other ones now. Let's see, these are used broad spectrum for gram-negative, gram-positive, widely spread in the body. They don't know yet if it crosses the placenta or the breast milk. Given IM or IV. Contraindicated in seizures and meningitis, breastfeeding, caution in pregnancy, only used in severe infections. Pseudomembranous colitis or C. diff, Clostridium difficile are big complications because it's such a powerful drug, wiping out the gut. It's not to be given if they're on valproic acid or Depakote, which they could be on a Depakote valproic acid for mental health issues or seizures, usually one or the other. This was just a good slide. It inhibits cell wall. Don't need you to know that. Broad spectrum, gram-positive, negative. It doesn't treat MRSA. decreased platelets, drug, fever, or adverse effects over here, seizure. So the only one is this, oh, I do know that one, Primaxin. I have seen that. Okay, so some common uses. So obviously the marum or meropenem does cross the blood-brain barrier because that one can be used on meningitis. If I told you to remember something from the slide, I think I would focus on this one here, the Primaxin, because that is one that might be used the most that you see. So I'm going to try to keep you where you don't have to memorize everything. I don't know what NCLEX is going to ask you. If you look at the N, P-E-N-E-M, it's on the end of every one of these. P-E-N-E-M, P-E-N-E-M, P-E-N-E-M. So carbapenems, if the drug ends in that, it's in this class. They're very potent. They cross the blood-brain barrier, can cause pseudomembranous colitis, contraindicated seizures, and meningitis, breastfeeding, and caution in pregnancy. Those are your key things to remember on that. Cephalosporins. Your cephalosporins are on page 108. Again, I'm hoping this picture will help you pull information together, giving you everything you can without your text. It's bactericidal and bacteriostatic, interfere with cell wall building. It is well absorbed in the GI tract. There's still four generations. Yes, 4 generations of the cephalosporins. Some of the old and good ones are still around, like cephalexin or Keflex. Everybody's probably been on Keflex at some point in their life, especially females for UTIs. There is cephalosporins might have a cross sensitivity. It says all in the family starting with cephalosporins. Oh, this is the 4 classes. This family is contraindicated for those allergic to penicillin. Not necessarily. It should be given with caution. It depends. There can be a cross sensitivity. They are not in the same class, cephalosporins and the penicillins. There can be a cross sensitivity. So it depends on the degree of reaction they had to penicillin or penicillin class, which the cillins, amoxicillin, but we'll get there. So if they had an anaphylactic reaction with a penicillin, you do not want to take a chance with a cephalosporin. If they only had like a little rash or something, you may try it because they may not be cross-sensitive. Watch for rash, anorexia, hypersensitivity, and GI pain are the major problems, potentials with this. Toxic to kidneys. So if they have renal insufficiency, you want to be careful of watching that or try to choose a different drug. GI symptoms of GI pain. Pseudomembranous colitis is a possible complication with the cephalosporins, so watch for that. No alcohol with cephalosporins until they have been off this particular class of antibiotics for 72 hours. Disulfiram, or I know it as Antabuse, is used as an alcohol deterrent. So if they're taking a Cephalcor and alcohol, if they drink alcohol when they're on a cephalosporin, it has the same action as Antabuse or disulfiram. I've always called it Antabuse. The Antabuse is given to people who are alcoholic and really can't want to stop, need to stop, can't stop. So they go on Antabuse or disulfiram so that if they drink, they get horribly, horribly, horribly sick. Flushing, throbbing headache, nausea, vomiting, blurred vision, chest pain, palpitations, dyspnea, and vertigo. So they're obviously not going to keep drinking. With the cephalosporins, that is the same reaction they will have if they drink alcohol. So no alcohol until they've been off the antibiotic for 72 hours. So which of these do you need to try to focus on? In your text, it's in table 8.3. No, you don't need to memorize which is first generation, second generation, third, and fourth. If you look at them, they all have something in common. Almost every one in the cephalosporins, even though cephalosporin CEPH, you will see your antibiotics in this class begin with the CEF. If you don't have a text yet, if you look in here, you will see cefuroxime, ceftin, cefepime, cefotoxamine. There is Cefnir. I said cephalexin, which you know is Keflex. I know NCLEX is going to ask you generic only. Last year I only gave generic on everything, but unfortunately I found it was hard for them because they see generic and brand names for the students out when you're working, when you're in clinicals and things. So I am giving you generic with the brand name in parentheses, but really learn your generics because that's what NCLEX is going to ask you only. But I want you to kind of be familiar with some of the brand names so you recognize them. So the cephalosporins, look for CEF or CEPH in the beginning of all of them. Those all fall in your cephalosporin class. So everything we said on it, toxic to the kidneys, watching for renal insufficiency, that's what you need to remember with all cephalosporins. Next class, fluoroquinolones. That starts on page 112 in your text. I was just looking back. On page 111, he gives a prototype cephalcore. No, don't worry about it. I told you just the CEF. Those are cephalosporins. Okay, don't want to get too confusing. Fluoroquinolones, page 112, contraindicated in pregnancy and lactation, which is breastfeeding, caution in seizures, and renal insufficiency. Most common side effects are headache, dizzy, insomnia, and depression. Can have GI issues, nausea, vomiting, diarrhea, dry mouth. Not as common as the headache, insomnia, and depression. Fluoroquinolones do make you sensitive to light and ultraviolet rays, so they should not be out in the sun, and they should not be in a tanning bed. Drug-drug interactions decrease effect with iron salts, mineral supplements, antacids. So if they're taking any vitamins, any supplements, anything, they need to take it 4 hours away from the dose of the fluoroquinolone. Fluoroquinolone can increase the theophylline levels. So for that COPD or that's on theophylline, getting IV theophylline. Fatal if on a drug which prolongs QT. There are many drugs that prolong the QT interval in your heart rhythm with your conduction in your heart. So if the QT interval, if they're on a drug that extends that and you put them on a fluoroquinolone, it can be fatal. So those drugs that it's fatal with are quinidine, procainamide, and some antidepressants, the tricyclics. The names of them, your text has it in table 9.4. There's ciprofloxacin, levofloxacin, ofloxacin, moxifloxacin. If you didn't pick up on it, the floxacins. So fluoroquinolones are the floxacins. So these are the ones contraindicating pregnancy and lactation, caution in seizures and renal insufficiency, common side effect of headache, dizziness, insomnia, makes you photosensitive, fatal if given with quinidine, procainamide, and tricyclic antidepressants. May increase theophylline levels if they're on theophylline. Let me see. What else do you need to know on them? This slide tells you, oh, tendon rupture. I've seen that actually once, but it was with ciprofloxacin, that there was actually a tendon rupture. So adverse effects, because adverse effect is a prolonged QT. If you put them on another drug, quinidine, procainamide, or tricyclic, that causes prolonged QT. That combination will make where the heart does not conduct and they will die. So, okay. Oops, next slide. Ciprofloxacin, which of course is a fluoroquinolone. You heard that fluoxacin for those hard to reach chronic bacterial infections. I just thought this was a really good slide on the fluoxacins in general. See, upper urinary, respiratory, GI, bone, ophthalmic, because it goes everywhere. Caution should be taken with seizures, those on theophylline, which we talked about. Hypersensitivity, history, these are all things we talked about. And that slide just kind of brings it together for you. Beta-lactamase, or beta-lactam antibiotics. Those are mostly your penicillins. Your penicillins and penicillinase resistant, your penicillins or beta-lactam antibiotics begin on page 115 in your text. Common things on all of them are caution with renal insufficiency, pregnancy, and lactation. Major adverse effects are GI and yeast infections. Drug-drug interactions is tetracycline. Penicillin is the most known of the beta-lactam antibiotics. Penicillinase is penicillinase resistant, so methicillin is one when it's a bacteria that's penicillinase resistant. You can give a methicillin, which is still a beta-lactam. It's the drug of choice in staph infections because it's methicillin resistant. Oh, I'm sorry. Staph infections, that's where MRSA, or methicillin resistant staph aureus, has come in, because it is one of those drug resistance that has developed from the overuse of the penicillins or psyllin drug. That's where methicillin, or you hear MRSA. If you look on here on names, again, don't worry about this part out here. It's the psyllins: ampicillin, amoxicillin, carbenicillin, ticaricillin, zollicillin, piperacillin, ampicillin, amoxicillin, the ones I've seen the most. But again, you're looking for the psyllins for it to be a penicillin or beta-lactam antibiotic. Here's a something to help you. Again, another slide, picture, if this works for you. Amoxicillin, just giving you some tips on learning what kind of infections it covers. Always check for penicillin allergy, especially anaphylaxis. Watch for diarrhea, nausea, vomiting. Major problem with yeast, candidus, and rash. It could be vaginal diaper rash in a child, and oral rash, thrush, which can literally go all the way down into the gut and cause a perforation. So it's nothing benign. I threw this slide in here to help catch your attention. The patient's allergic to amoxicillin, so you want to prescribe Augmentin. Amoxicillin is amoxicillin clavulanate. It just has the clavulanate to kind of potentiate the effects of the amoxicillin, to work deeper, stronger on some really tough bugs, or to decrease the resistance to some of the penicillins. So that's when you have Augmentin or amoxicillin clavulanate. So that is where the nurse has to come in and question knowing that I don't think this is correct. I just thought that was a key picture, help bring that point home. I know, there's a lot of classes. Next class, sulfonamides. Your sulfonamides begin on page 120. They're tetragenic, which means they cause deformities in babies, so nobody in pregnancy and careful with childbearing age and making sure they are taking precautions for pregnancy. It does go through the breast milk, so it is contraindicated in pregnancy and lactation or breastfeeding. It can cause a sun sensitivity. It peaks in 3 to 6 hours. It's contraindicated if allergic to thiazides. There is a cross-sensitivity with thiazide drugs, so thiazides and sulfonamides. And you have to be cautious in the elderly because of central nervous system symptoms. Unfortunately, the names on this sulfonamides is not real easy to remember. It's ones that you just have to learn. A couple of them, like sulfadiazine and sulfasalazine, obviously are sulfa drugs. The one that might be harder is the cotrimazole oxazole, which is Septra or Bactrim. You probably know it as Septra or Bactrim, or Bactrim DS, which is double strength for certain infections. Looking here, drug-drug interactions. If sulfonamides are taken with glyburide, glipizide, hypoglycemic drugs, it increases the hypoglycemic effect, which is something to be very cautious. Your text does have a whole box of nursing considerations for patients receiving sulfonamides. If they're allergic to it, to be not to give it if they're allergic, but allergic reactions to sulfonamides can be significant. Again, totally contraindicated in pregnancy. A good chance for having an adverse effect of a rash or oral thrush. Monitor their renal function, BUN and creatinine. It might cause some blood dyscrasia, so you're checking their CBC. Anything else that I want to pull out of here? Let me see. Said CBC. What good mouth care. Give it on an empty stomach for better absorption, so that's 1 hour before a meal or 2 hours after, because food will block absorption of the drug. I think that's really it. When you get your text, you can look through, but I think that's the major points. Go here on, let's see, tetracyclines. Start on the bottom of page 122. The tetracyclines, the one names to remember: doxycycline, monocycline, tetracycline. Tetracycline is an actual antibiotic in the tetracycline class. So the cycline, C-Y-C-L-I-N-E, is the ending on anything. If it has that, it is a tetracycline. Commonly used for treating pertussis, which is whooping cough, for people that don't get their tetanus or their Tdap, and H influenza and some other things. Only contraindication is if they're allergic and children under the age of 8, because it can stain the teeth. Some caution with hepatic or renal dysfunction. It's a major one for photosensitivity. I know the others can cause photosensitivity, but it is extreme with tetracycline. I had a patient get a second-degree burn going out to gardening when she was on doxycycline. Drug interactions are with digoxin. It can cause a digoxin toxicity, and it stops the effects of birth control pills. It also, just like the sulfonamides, needs to be taken 1 hour before or 2 hours after a meal because food blocks the absorption of the tetracyclines. Table 9.7 just has those the tetracycline minus cycline, doxycycline that I said. Adverse effects: the abdominal pain, glossitis, which is the swelling, inflammation in the mouth, dysphagia, difficulty swallowing. Photosensitivity is the hugest thing. Told you about not taking it with digoxin. And the next slide. Oh, no, I thought the next slide was on it. Sorry. Let's go back here. Talk about INH in a minute. There is a whole section on antibiotics and oral contraceptives. Just remember, anybody that goes on an antibiotic that's an oral contraceptive, they should use a secondary secondary protection, because all antibiotics, tetracycline just has to be one of the major ones. All antibiotics can decrease the effectiveness of a birth control. Okay, so now let me move on to here on INH. This is an antimycobacterial. Antimycobacterials are TB drugs. TB and leprosy are caused by mycobacteria. In this country, really, it's just the TB. I don't know that we have cases of leprosy. Probably do. So INH, or isoniazid, is a major antitubercular drug. It's used for prophylactic treatment if you've been exposed. It is completely metabolized in the liver, so it is contraindicated with liver dysfunction. It can also cause an acute hepatitis. I was exposed to TB years ago, had a grossly positive skin test. They put me on INH. In 2 weeks, my liver's enzymes climbed drastically. They decided to wait 1 more week or 2 more weeks, because they said sometimes the INH goes up initially because it's the liver enzymes go up because it's completely metabolized in the liver. In 2 more weeks, I was sicker than a dog in bed. I stopped taking it. The nurse from the health department called me, asked me if I went in a drinking binge, and I said, I don't drink. She told me to stop the drug, which obviously I had already done. Thankfully, my liver function went back to normal. It was not a permanent damage, but I'm telling you, in 3 weeks' time, it had my liver almost completely shut down. Okay, so antitubercular drugs, antimycobacteriums. Isoniazid is the major one I want you to learn. Let's see. In your text, there's a table 9.8. When you do get it, 2 drugs to focus on are the INH, or isoniazid, and 3 drugs, pyrazinamide and rifampin. Those are the 3 to be familiar with, to know that those are antimycobacterium or TB leprosy drugs, because they're often used in a combination of a couple of drugs for appropriate TB management. We're almost to the end. I think this is 2 more. This one and 1 more. Usually leave out a syllable on this one, but it's lincosamides, page 132 in your text. They're very close to the macrolides, but they're more toxic. Like, remember, the macrolides were the ones with the mycin ending. The lincosamides are closely related, sort of like cousins. The ones that go in this class are clindamycin and lincomycin. Unfortunately, lincomycin is one of those ones that has been overused and is has a lot of resistance now, so clindamycin is used more. So out of these, really focus on the clindamycin. It's good for lots of bacteria, penetrates all the tissues, but it has a tremendous amount of side effects. Just flipping through the text to realize there's a couple of things I skipped in here. So when you get your textbook, the ketolides on page 130, we are skipping. You come to page 132, lipoglycopeptides, we skip that. Lincosamides are on 132. We're doing those, but we're not doing the lipoglycopeptides. And with the lincosamides, focus on the clindamycin. You have a little thing, if prototype summary in your text on it. Inhibits, let's see, what do I want you to know? Metabolize in the liver, excreting the urine and feces, adverse effects, nausea, vomiting, diarrhea, pseudomembranous colitis, and bone marrow suppression. That's with any of the other, like the macrolides also. The pseudomembranous colitis, caution hepatic and renal dysfunction. It can be the clindamycin, you'll see used IV in severe bone infections like osteomyelitis, but it's such a strong drug, it should not be used willy-nilly. It's the best word I can come for that. Tell my age when I use a word like that. Okay, actually finally to the last slide, macrolides. Macrolides are on page 133. The one to remember with your macrolides is your erythromycin. That's the one I want you to focus on. Again, hepatic function, caution, lactation and pregnancy, caution, adverse effects, GI. GI is big with erythromycin, really big. But some other things, central nervous system problems, symptoms such as confusion, uncontrollable emotions. Some major drug interactions with digoxin, anticoagulants, theophylline, carbamazepine, and corticosteroids. So be familiar with the drug interactions. This little slide up here, even if you don't have your text, this slide is really going to help you. Azithromycin, it's macrolides, sorry. Azithromycin, you should be familiar with azithromycin, but again, there goes your azithromycin and erythromycin, different from the macrolides. So don't get them confused. I mean, from the macrolides, different from the. No, oh, I'm getting tired. I apologize. So you have the mycin and the clindamycin is the major one. That's the lincosamide. And on here, I want you to know with azithromycin and erythromycin. Azithromycin people should be familiar with. They hear the Z-Pak, which is azithromycin. Anything else here? It's used for all kinds of infections, including STDs. See, we're not going to do the monobactam antibiotic. So that gets you to, that gets you to the end of this chapter, and one more to go, and I apologize, I'm just getting tired. I'm going to try to get through. Oh, I might do the last one tomorrow because I think I'm too tired to make my way through this. Thank you.